So we have a question from, before we get started, thank you for each of the speakers today. We have a question from our Zoom audience. One question from Dr. Peak: how can primary care physicians increase transplant rates for their patients?
Yeah, I think my thought there is primary care doctors are pretty upstream, but I think ensuring that patients are healthy enough for a transplant and educated about their options, that they get referred into a transplant center, that can happen through a lot of different sources, whether through a nephrologist or a PCP or the dialysis facility. And then I think sort of talking with the patient about their options so that they understand the different steps in the process. It really is a process, that the patients have to get their colonoscopies. They have to get all of their different checks and steps there. There's a real role in kind of helping to make sure a patient can do that to remain active and be a real candidate, as well as I think education about the living donor transplant process. And I think beginning that discussion and in general, the discussion of the transplant process as soon as possible so that patients can know that that's an option and sort of make themselves the best possible candidates for it.
I would just build upon that to say that the importance of the patient-physician relationship is critical, and trust is critical. And I think often the primary care physician is someone that the patient has known for a number of years and may trust and really believe that individual when in a situation which may be hard to accept everything that's going on. And so they may be able to support and do that early referral to nephrology. And so I think there is a critical need, and also critical need to stay within the conversation to keep encouraging the patient to go forward.
And related to that, Tom, you had mentioned that the first model failed to integrate with primary care. There was a failure of integration. How was that assessed?
Well, the model. Sure. So the model focused just on patients once they hit dialysis, and it was just focused on that care relationship with the dialysis facilities and the nephrologists. I mean, it was an explicit choice because we were just trying to test proof of concept to see how well coordinated care would work in the space. So part of the goal was to shift in the second model, then was to shift further upstream to focus on CKD patients there. Yeah.
Question that crosses multiple speakers. So Michelle talked about, creating the office of the chief kidney officer within HHS. And Tom, you were talking about, how primary care wasn't integrated into one of the earlier models, the CEC model, I think. And then I'm thinking about Jim's talk about and actually Milda's papers about the importance of the social environment, neighborhoods, on outcomes for people with chronic kidney disease. So I guess my question, let's say that there wasn't an office of the kidney in HHS. What sort of, I was thinking about, Tom, your work in CMMI, which focuses really on Medicare, but are there sort of innovative ways of thinking about bringing together multiple payers to try to address more upstream factors? So the obvious one is Medicaid and Medicare, and thinking about maybe doing something with duals with CKD, and expanding the model, outside of people with ESRD.
Yeah, I think that's a definite possibility. Everything kind of builds on itself and you build on the lessons there. I think one of the big avenues for the future is that, the models the KCC model starts with CKD 4 and 5. There's a whole lot before there, and a whole lot of opportunity. And especially with the growth of these new, the GLP-1s, the SGLT2s, and that we're just sort of assessing their incredible effects on CKD prevention and slowing down that. I think that's a huge opportunity. One challenge also is just the payer fragmentation, where Medicare is the one who sees the long-term benefits for, each year of avoided dialysis, or as a patient doesn't progress. That saves Medicare a lot of money, but it also is sort of future hypothetical money that's saved. It just makes it difficult to account for and to pursue there. But yeah, I see some major opportunities the further up within CKD, and then even back into diabetes that you go. All that has reverberating effects on expenditures and on the Medicare population as we go along.
Sorry to take us back down towards transplant when you were getting up, but as part of IOTA, I'd be curious, are you thinking about requiring transplant centers to accept Medicaid to incentivize preemptive listing for patients who don't have private insurance?
We don't have any requirements on that. I think one requirement we do have, though, is we evaluate transplant centers in the model based on their performance across all payers. And we'll also have the evaluation look at, is there any change in payer mix there? Because we don't want just an increase in Medicare transplants just by, taking them from Medicaid patients. So that is why we look at overall center performance regardless of payer there. I think we'll look at that Medicaid angle there, and just sort of see and think what makes sense.
Yeah, I have a comment and a question. So I was thinking about the same thing that was just brought up, and this might sound a little socialist, but you could create an eligibility of an EGFR of 20 for Medicare, Medicaid. And that makes it very easy then for individuals to come in for preemptive transplantation. And that would just be an advancement of the current model for ESRD. So I think that was where I was thinking before all these comments came up. But the other thing I was going to ask about is, it's interesting that with the most recent new model, there really wasn't an impact on hospitalizations or emergency room visits. And these patients are seen once a week by a physician, 3 times a week by healthcare providers. They are a captive audience. So my concern is there's a very large force outside of the provider network that is still negatively impacting all of the efforts of the care models.
Yeah. Yes. So I think a few different thoughts. One is, this was year one. This was 2022, where there was still a lot of COVID going around, that was affecting everything. We heard from folks, it took them a bit of time to fully implement their care model and really get started. That accountability was for that whole year, but that they didn't get their investments and see that over time. I think part of our hope is we'll see, given the progressive or regressive nature of kidney disease, that you'll, especially from the rise in optimal starts, that we'll see reverberating benefits to that over time. We also basically doubled the model size, where we had 50 additional folks join for year 2 in 2023. So we'll see how those results go. So it's kind of a different model, or it's really a different cohort there. But yeah, I mean, hospitalizations to me are the single most important metric for this. Obviously, I would have loved to see that, but we sort of saw some good quality indicators, and we got to evaluate the overall path and just seeing how that's why we do a model test for 5 years.
Right. And I appreciate that those all may really help. But I think at the end of the day, if you find out that there is this undefined yet impact outside of the healthcare providers, and I think where I'm going with this is there's a real restriction on providers and the care that they can give in many of the dialysis units, what power does CMS or anyone else have to respond to that finding?
I mean, it's part of honestly, that's part of an inherent question in the model test of, can provider incentives help to fix this and lead to an increase here? I think with ETC, it's looking like that specific provider incentives may not necessarily lead to that direct increase in home dialysis rates there. I think for KCC, that is part of the test, or are all of the other barriers faced by kidney patients and the burden of disease there and all the sort of SDOH barriers that the lack of a social safety net can't, that you can't overcome all the sort of broader societal issues there that then lead to poor health outcomes there. And is it possible for providers to overcome all of those barriers using just sort of the power of financial incentives? Yeah, I mean, I just think a lot that I just thought that Mexico City comparison, I just keep going back to that slide because it was a heck of a slide. And what it shows is I think some of the impacts of diet and lifestyle and living in America there that are difficult and don't necessarily lead to the best outcomes.
Hi, for the last speaker, I had a question. You mentioned collaborations of care or coordinated care. So that was the first time I heard that today. And I work with the National Kidney Foundation, and we work with community health workers. So I know CMS is in the process of certifying and licensing, and there are some that are already in place with community health workers. And I wanted to know on a broader perspective, like, what are they really doing or are they really moving forward using more community health workers in collaborating care for people with CKD?
Yes, I think so. That's been one of the main interventions we've seen with the model is a lot of like hiring the care coordinators, staff, hiring the people to work one-on-one with patients. And that's been a lot of the interventions that we've seen is that greater investment in community health workers and care coordinators and nurses to help support patients there. Essentially providing, I think part of the thesis here is that nephrologists do good care, but that what is needed is not necessarily nephrology care, but a lot of that supportive care to be able to spend that time, on the phone with the patient to overcome their issues around housing, their issues around, getting good food that are really necessary to achieve the medical goals, but sort of provide that barrier. And I think bringing in some of these non-nephrologists are the keys to really help make that happen.
Following up on that. So thinking about that, you mentioned sort of the upstream causes of kidney disease or, really kidney disease is a pathophysiological disease, as a disease of poverty. And so what are some upstream policy changes to both reduce kidney disease or improve kidney disease outcomes or non-medical interventions that CMS can fund or that can be funded through the healthcare system to sort of improve those outcomes?
Well, no, I mean, other people can answer too, but I think this shows it's just an inherent limitation here. The Medicare statute limits it to health-related issues, and it shows that so many of the issues are non-health related but have health effects. And we try to treat them through these issues through the healthcare system when a lot of these are non-health related issues. That's one of the things called social safety net.
No, yeah, that's.
Yeah, one of the slides that I had to skip because I had too many, showed within CRIC, this nutritional epidemiologist looked at healthy diet patterns, and there was like remarkable in terms of individuals who were had high scores for the DASH diet or Mediterranean diet. They had lower rates of CKD progression, and so that incorporating that types of care and approach in our preventing CKD and preventing CKD progression is super important. Difficult to implement.
I was also going to say, I know that a number of folks in this room are involved in or very interested in diabetes care and diabetes prevention. And I recall there was a study which looked at exercise interventions as a preventative measure for worsening diabetes. I don't know if there are comments or any parallels we could make thinking about non-medical therapies in this arena.
I think you might be referring to the diabetes prevention program, which became under I think during the Affordable Care Act, the National Diabetes Prevention Program. Lifestyle, so that's a kind of a success. That's from a trial to translational research. I think there was a CMMI experiment that helped solidify Medicare payment for DPP. Interestingly enough, it's hard to get people to sign up for DPP, and there are all kinds of problems in rolling out the actual program and getting community organizations to be DPP providers. So it has actually some of the same kind of trajectory that Michelle referred to. There was like kind of a golden time, and then now we have the reality of running this program. It's not. So anyways, diabetes and then lifestyle in general. Yeah, there's the same exercise program worked for people with diabetes and for people with pre-diabetes. So I don't know if CKD has the same kind of kinds of interventions, that kind of evidence base as well. A lot of things we're talking about are way past, but we should really be investing in prevention.
I mean, and let me just say, yes, individual prevention, but I think prevention sort of at a larger scale because it's sort of hard to avoid the food, to afford the foods for the Mediterranean diet and to do all of those things. So don't want to.
Yeah, so a quick question in terms of, your point on not CMS not necessarily being a funder or a supporter for upstream interventions that may impact healthcare but aren't like one-to-one. Obviously with Medicare Advantage being a large portion of, CMS's expenditures, and obviously I know that's more of a capitated payment to these providers that they can kind of do what they deem is best for the patient. Are there any limitations or statutes preventing, these Medicare Advantage organizations for like investing in, housing or quality foods for their patients that Medicare stipulates?
Yeah, I think we've seen some of those interventions within MA. Like I know like gym memberships is a big one, and there is definitely some with like doing food related interventions. Yeah, I think a lot of the plans are trying this out through their supplemental benefits to see. Yeah, now supplemental benefits also come from the proportion of premiums that they sort of saved relative to it. It's based on their premium costs there, and some of the funding that they receive there from CMS to help pay for their for the patients there. So yeah, that's a definite opportunity that MA plans have, that greater flexibility to I think to think about that and potentially help patients.
Tom Duvall has already addressed this, but I just wanted to see if other panelists wanted to talk about the intersection of healthcare policy and innovation from financialization in this industry.
Just to step back in time, I think the financialization of the dialysis services really affected. I mean, I think, on the slide I showed it I think you could say that it truly affected the investment in NIH funding, how much the government was willing to pay for research. And so I think it's had a profound effect, over time, historically, which continues to, continues to have reverberations over decades. I mean, I think things are getting better potentially, and there's been a lot of pressure to increase NIH funding in the kidney space, but I do think that was an effect in how much government was spending on, you could understand it, right? But at the beginning, but you can understand that, but how much was spent on dialysis care has had, I think, unintended consequences for the innovations that we could have seen in the nephrology space.
Maybe I'll take a liberty to ask a question of my co-panelists. So a lot of these innovative payment models and the research generated by Kirk and there's this effort to prevent chronic kidney disease and make it never occur. That seems unrealistic in the short term. And then a lot of policy measures seem to be aimed at keeping the patients on dialysis alive longer. So the end stage kidney disease population may end up growing as a result of these interventions. So I wonder how sustainable it is for CMS to take the no hands or hands-off approach to the allocation algorithm when, right? Like when that's the most effective treatment we have for this population, to just leave that in the hands of the transplant community. Just, curious on Tom's thoughts or other people's thoughts. I assume that the transplant community would have more perspective here. Yeah, yeah, exactly.
Yeah, I think one is that's Congress. Like Congress set up the OPTN through the Public Health Service Act. They set up CMS through the Social Security Act. So the Public Health Service Act has that authority and in those areas. And then Congress created the OPTN. Congress can change whatever they want. I think the other piece too is, CMS in acting as the payer. What we are trying to do through the IOTA model is to push for better value for what we're getting for our dollar. That's one framework for looking at it there of, CMS pays out billions for transplant costs and DRGs and organ acquisition costs. So it's trying to demand accountability from those who we are paying and those who've, and like the OPOs who've had these contracts for a very long time. So I think that's the goal, is we're trying to get sort of more on behalf of our patients and better value for our dollar there.
Yeah, it just seems like you create policy incentives to get transplants performed for centers, but the core allocation mechanism you can't touch with a policy lever, which seems like an interesting limitation. It's almost like you have a hand behind your back. You're trying to incentivize transplantation in general, but the allocation algorithm itself is under a different regulatory framework.
That's true. And there's one or two flaws with the algorithm at this point, I could say. I think we're just in a world where I think there were 20 million offers last year and about 20,000 accepted kidneys. So that's a pretty poor ratio there. And that suggests any other algorithm that had a 99.9% failure rate would probably be thrown out. So it's one that just suggests something fundamentally flawed in how the algorithm has been implemented and in how the allocation system exists, such that now there's that massive rise in out of sequence allocation. And what are seen as potentially unintended effects have become the main effects of it. So that's also why the IOTA model includes a focus on organ offer acceptance rate, either focus on increasing the numerator, so accepting more organs and getting more folks transplanted, or decreasing the denominator. So it's not getting anybody else transplanted, but it's helping to increase the efficiency of the overall system and helping to, I think, sort of save everybody a lot of time and effort.
So yeah, while IOTA doesn't mess with the rank ordering, hopefully will make the actual organ allocation system more efficient.
So Tom, I'd be interested in whether you look at that as more under the HRSA sort of jurisdiction, and with this relation to OPTN. But I think you've just made the case for the need for the Officer for Kidney Health and Transplantation to bring it all together.
I have a comment. I apologize for coming late. I'm Rolf Barth, one of the transplant surgeons. Dr. Semino and I were just in the OR, so this may have been addressed or off topic, but maybe for Will and Michelle, and don't tell anyone outside of this room that a transplant surgeon is asking this question, but realistically, I mean, how many kidney transplants should we be doing? And whatever the data of 600,000 on dialysis, 100,000 on the list, 26,000, 28,000 kidney transplants a year. I mean, we can tell you that we've tripled our volumes over the last 6 years, but it's been at the edges, and the kidneys that we're using on those edges, the out of sequence allocations, the patients that wouldn't have been transplanted 3 years ago, they're a lot more difficult to take care of. They cost a lot more in the hospital. The organs don't last as long, and the survival benefits change significantly. I think there is a little bit of mythology that there are a bunch of great organs going in a trash bucket. These organs, have significant factors that affect their viability, the life benefit to the patient. And again, the cost of using these organs sometimes becomes really substantial. So, I'm curious, where is that sweet spot in the US, or what other demographics or models exist to predict with the burden of ESRD, how many of these patients should actually be moving to transplant?
I have thoughts, but
Yeah, I'm gonna actually hand the microphone to Will because he has thoughts on this.
I mean, I showed Ralph the Albert's JAMA internal medicine study comparing the US to France, and the kidneys that are currently transplanted in Europe and in France, and the outcomes there. Sure, the post-graft survival is lower, but they do a lot more transplants. They get a lot more people off dialysis, and they save a lot more life years overall. So there is, I think the US has to catch up to Europe in that for sure, but there is a cap at some point, for sure. And where the cap on the total number of viable deceased donors that we could possibly procure and transplant into a patient and get a positive survival benefit still is far below the 300,000 or so patients that could hypothetically benefit from a kidney transplant. So in the end of the day, there's going to be an absolute scarcity and the algorithm will be relevant with sort of my thoughts, but I'm curious to hear what Tom says.
Okay, while Tom's gathering his thoughts, I'd also say that I think it's also, those are incredibly important points. And it's not just about transplant access. It's also about being able to provide care after transplant so that these transplants will survive. And so, you know, when I showed that graph about the dropping number of nephrology trainees and just lack of interest in nephrology nurses in nephrology care, I think we have to be realistic, because to do this well and to have patients really benefit, we don't want to just give them a transplant and have them lose the kidney transplant. We need to be able to take care of them. And they are, as Dr. Barth said, they are much more complex. These individuals, they require a lot more care, very difficult care. We need to be realistic about what is required for these models to work. So I think it's got to be the modeling, but also being very realistic at the program level, at the level, and really engaging the hospital highest level administration to provide us with the resources that all of us need to attain what we would like to attain in terms of increasing access and then long-term outcomes.
I just can't flip a switch. Yeah, can't flip a switch and be like France, I guess. You have to have the workforce, right?
Yeah, I think my answer is more. No, I don't have a definitive answer, but you know, the number of organs procured is going up each year by a pretty substantial margin. So that's an increasing supply. The IOTA model says we'll take your historical numbers there and you have to increase it by the average national growth rate. So it's trying to recognize that as supply is growing, and if everyone else can increase it 5%, can you increase that 5% each year? And another piece of it too is, you know, I think the investments that a center like Chicago made is wonderful to go to triple your numbers like that in 6 years. I think that's great. And the question is 6 or 7 or 8 years ago, could you have said, my gosh, we have a target to triple our numbers within 6 years? That seems impossible. And I think that kind of innovation is really helpful. I think 2 other key areas to think about. One is, do you know the fate of every organ that you turn down? Like, were any of those used by another center? And if they were, what did that center see? And you know, was it that the patient wasn't the right fit, or was it that they sort of saw the organ in a different way you did? And what were the results for that patient? And just to do that looking and thinking and use all the reports that are in from the OPTN to kind of see what the effects and results from your allocation decisions were. And the other one is living donation. You know, there's massive variance in the number of living donor transplants done by hospitals around the country. There's one in San Antonio that does over 200 living donor transplants a year. And I don't think it's that the people of San Antonio are that much more giving that they'll just like pass out a kidney to you when you're on the street. But it shows that like living donation is it's a process that requires a lot of investment, a lot of effort to work with patients, build the networks, build the swaps to help make that happen. But I think there's a tremendous amount of lessons to be learned there in how to increase your numbers, how to invest in those processes to help get more folks through the process. And I think what we're really hoping for with the IOTA model is to get each center to just think really critically of how can we increase our numbers? What are all of our different levers? How can we look at all of our deceased donor options, all of our offers, our offer patterns? How can we look at our living donor program with the goal of seeing the increases and really getting more patients off dialysis?
I think one of our challenges, first of all, I mean, 300,000, I would love it, you know, if we could get 300,000 people listed in the US, it gives me good estimates for the hospital of how many transplants will do over the next 5 years, and they'll be pretty happy if I want to triple again. But the problem with the data that I see, again, is the number of procurements and recovered organs and the phone calls I get in the open offers in the middle of the night are clearly up. But, and we do get data and get reports, and OPOs have become better about sharing the distribution of those organs, but it's binary, it's transplanted or not. You almost never get 1-year survival data. It does exist, but it's almost never reported on those discards. And I've never seen any functional data. So, and I think that's even with our current metrics in transplant. We never see how's the center performing that in terms of 1-year patient graft survivals, but what are the functional outcomes? And when I was on the East Coast, we were the largest center in the US for kidney transplantation. And we had a lot of severely impaired graft function at 1 year with people with creatinines, 2s and 3s. And we still don't have access to that data, which seems to be necessary to make any real conclusions about allocation, utilization, and rates. If suddenly we told you that we could double the volumes, but you're going to increase, you know, severe graft dysfunction and decrease graft life for those patients, but only 18 months or months, people would suddenly change all of their things.
Yeah, and I'll say the OPTN has all of that data. And I think as we implement the IOTA model, I think our goal is going to be to share and figure out what data is most useful to share with participants to really help folks. They have GFR at 1 year. It is not. It may not be, but they have that data.
All right, so
Yeah.
Tom is going to be at lunch, and so we welcome, and so you can join him. But right now, I want to have you join me in giving a round of applause for all of our speakers. And then for 2 housekeeping things, here's a QR code. We want you to share your feedback and ideas for future topics. And then we'd also like everyone to come up to the front because we're going to take a symposium picture.
And then there's lunch afterwards.
So the sooner you get up here, the sooner.
Yeah.